Hi, Dr. Jacobson. So I decided to do my final presentation, as you know, on pedophilic disorder. So let's get started. Before I really dive into this topic, I just wanted to adhere a warning to anyone who's watching and anyone in the classroom. This topic generally tends to trigger individuals based off their own personal experiences and or their feelings on the topic. So knowing that, if you feel uncomfortable now or at any point throughout this presentation, please do not hesitate to leave. I want everyone to feel comfortable while I'm giving this presentation. That being said, what is pedophilic disorder? Well, according to the American Psychiatric Association and the DSM-5, there are 3 specific criteria that must be met in order to be diagnosed with this disorder. Those 3 criteria are broken down into first criteria A, which is over a period of 6 months, recurrent, intense, sexually arousing feelings, fantasies, sexual urges, and or acts must happen with a prepubescent child, which is usually 13 years of age or younger. The second criteria is that individual has to have acted upon these urges and it has caused them marked distress or interpersonal difficulty. The third and final criteria, which is criteria C, is that this individual must be at least 16 years of age and has to be at least 5 years older than the victim or individual that they're engaging in these sexual acts with. So that's basically the 3 criteria that kind of break down how to diagnose this disorder, but let's talk a little bit about the history of the disorder itself. It has been known throughout time and all of humanity to have existed, but it didn't come to be about and wasn't formally named until the 19th century. After that, it was first included in the first edition of the DSM, which was in 1952, and since then has been edited and kind of shuffled around throughout all the versions of the DSM, but found its home in the DSM-5, which is the current version we use today, within paraphilic disorders. Let's talk a little bit about the prevalence of this disorder. It's actually unknown, much like the history or where this disorder actually first began. But the highest possible percentage that we believe for males, according to the DSM-5, is anywhere from 3 to 5% of the population. When it comes to females with this disorder, it's even more scarce, and it's even a smaller fraction of what the male prevalence is, and it is also unknown what the exact number is. The development and course and risks of this disorder. The development actually starts around the prepubescent age of males. That's when they usually develop their strong interest sexually, as well as females when they hit that age. It's really, really difficult to diagnose these individuals in that time frame because of the conflict of age that they're actually in, and their sexual interests in their peers are too young to really tell if this is a disorder yet or if this is just normal developments happening. When it comes to the continued development and course of this disorder, it's important to understand that this appears to be a lifelong condition. It may change over time with or without sexual treatment, but overall it seems to be something that stems throughout an entire person's lifespan. When it comes to risk, there's temperamental, environmental, and genetic. The temperamental aspect comes with the antisocial personality disorder, which can be considered a risk factor for males because those with both antisocial personality disorder and pedophilic disorder have a much higher chance to act out sexually towards children. When it comes to the environment, this is actually a huge factor in this disorder. Usually males who have been or who have this disorder or are convicted of engaging sexually with younger children were sexually abused by their parents when they were growing up as children as well. So it's an important piece of assessment that we have to look into when we get our clients. So the case study with Charlie. Before I show you guys the video of Charlie and myself as the counselor, I'm going to read you guys his case study so you can just get a little bit better idea of what Charlie is actually all about. So Charlie, our client, is a 33-year-old male who is recently convicted and charged as a sex offender. This is Charlie's first conviction and first ever issue with the law outside of minor traffic violations. Charlie was arrested when his girlfriend of 9 months had come home early from a business trip and found him raping his 6-year-old daughter in front of his 4-year-old son, who was being forced to watch. Both of Charlie's children were from a previous marriage when he had recently divorced and moved in with his current girlfriend. Our client's girlfriend, as well as his family, friends, and colleagues, were shocked to find out that this was happening, as Charlie has lived an extremely successful life as a business tycoon. He is extremely educated, attractive, is very good with money, and was described as a charming individual, which is why so many didn't expect this type of behavior out of him. Our client reports being violent with both of his children, sexually with his daughter, and physically with his son in order to keep his son quiet about his interest with his daughter. Charlie was previously abused by his father, both physically and sexually, and Charlie claims that his father would get out of him what he couldn't get out of his mother. Although Charlie has also had a younger sister growing up, his father only kept his sexual interest on Charlie. However, Charlie reports to us about having sexual feelings for his younger sister growing up, but never actually acted on them while he was with her, and as she became of age, those interests actually faded away. Our client here reports that he has been attracted to children, especially females, and he currently is, but he has slept with women and used his previous wife, marriage, and current girlfriend as a facade. He reports only being able to have sex with these women after secretly watching child pornography in order to get aroused. There have also been situations where he reports watching child pornography on his phone while his wife gives him oral in order for him to get off properly. This has caused Charlie significant clinical distress in the sense that he leads a perfect life outside of his sexual interests and has been forced to keep his sexual interests a secret and build a secret life in order to remain hidden. He states, "You can't imagine being revolted by what you are every day." He reports avoiding children his entire life to avoid acting out on his sexual urges. However, once he got married and his children were always around, the temptation was just overbearing, and Charlie began abusing his children about 2 years ago and admits that he needs help. One of the statements that Charlie makes is, "It's not normal to get turned on by little girls," and he has no prior record of mental illness and or substance abuse. So that's Charlie in a nutshell. That's the case study that we received from him. Let's go ahead and watch the video. Dr. Jacobson, at this point, I sent you the link, so it might be easier for you to just watch it instead of me playing it on this so the file doesn't get too big. Hopefully those links work, and if they don't, I can send you the video recording itself. Alright, so now that you guys watched the video, you got a little bit more of an idea of who Charlie is outside of the case study that I read you. So let's talk about the justification for Charlie's diagnosis. Charlie is 33 years old, which is old enough for the diagnosis, and he is significantly older than 5 years from the victims that he was abusing, seeing that his daughter was 6 and his son was 4. At 33, he is obviously above the age of 16, so he is diagnosable. The second criteria, the sexual abuse of these victims has lasted over 2 years. So if you can recall when I was talking about the diagnostic criteria, it was that the urges have to be acted out or happening over a period of 6 months. This is 2 years, so he's well over that time period. And when it comes to the last criteria, the different ways that he's been acting upon these urges. One, he's watching child pornography on his own, as well when he's engaging in sex with his wife secretly that she didn't know about, and his girlfriend. He's been raping his 6-year-old daughter, and although he hasn't been sexually touching his son, he has been forcing his 4-year-old son to watch that rape happen. A couple more areas of justification for the diagnosis. Charlie reports clinically significant distress. So if you can recall back from the case study that I read you, he talked about how he was hyper-focused on building a perfect life outside of his sexuality and his relationships. That can cause enough stress in itself, just trying to keep that hidden his entire life because it's not accepted by society or basically anyone in general. He's had to avoid children his entire life because of this, probably having to make excuses to get out of situations where he's being involved with children, which just adds stress on top of that. And he admits feeling extreme shame and guilt. You notice within the video that he was very aware of what he had done and was very, very upset about it. Now that can happen one of 2 ways. You'll have individuals who are not accepting of what they've done at all, and then individuals that are. So we're going to see both in our office, and we just have to understand how to handle each one of those individuals. So when it comes to specifiers, our client Charlie has 2. He is non-exclusive, and he is sexually attracted to females. Although he is non-exclusive, because he was previously married with a child, where he was both sexually and physically involved with his mature woman, which was his wife, as well as his girlfriend. Even though he mentions using those relationships as a cover-up, and that he's always been sexually attracted to children, he's still engaging in those sexual acts with them, so he is not exclusive. And he has only focused on females, as you can see, with only sexually abusing his daughter and not really having any involvement with males other than having his son watch. Let's go over the differential diagnosis. So there are only 3 potential differential diagnoses to include when talking about pedophilic disorder. They are antisocial personality disorder, alcohol and substance abuse disorder, and obsessive compulsive disorder. So I'm going to talk a little bit about each one of these and how we can rule them out as potential diagnosis for Charlie based off the case study in the video that you just watched. So antisocial personality disorder, we talked a little bit about that earlier and how paired together individuals will have much higher risk of sexually engaging with others. However, having this disorder it does increase the likelihood of those who are sexually attracted to mature adults to approach children, but it is usually based off relativity. So that's kind of the key word in this that kind of separates it. It's based off relativity and not something that's constant. So someone who has pedophilic disorder is always attracted to children, and that has always been the case, even if they are attracted to mature adults as well. People with antisocial personality disorder also tend to have history of previous criminal records. Charlie only had minor traffic violations, so he doesn't really fall under that category as well. Alcohol and substance abuse disorder. This one was pretty easy. Charlie has no previous record of alcohol or substance abuse disorder. However, someone with this disorder, because of that, it inhibits, has disinhibiting effects when they're intoxicated, which can lead those individuals to sexually approach a child because of the way that the alcohol and the substance abuse is affecting their minds. And the third and final would be obsessive compulsive disorder. These people tend to complain about an ego-diagnostic thoughts that, and they worry about their possible attraction to children. So they're very, very worried about their thoughts towards children and not so much actually acting out and having that deep desire to be sexually involved with children. That one was pretty easy to rule out for Charlie as well, because this was not a thought or a worry thing. This is something that he's had basically his whole life since he was a teenager, and he knows that he's been sexually attracted and avoidant of those feelings for a very, very long time. So, a little bit about legal and ethical issues within practice. There's several things here. We're going to touch on each one. So, importance of clients and therapist relationship and interface when your client comes in and has this disorder. So, the first step in treatment is usually to engage the client, and pedophiles and people with this disorder are usually very, very hesitant and resistant to do that. Previous clients who have had this disorder that have come in to talk to therapists have reported that the therapists tend to be highly confrontational at first, and the client ends up developing an ego defensive strategy that can be misinterpreted by the therapist as denial for what they're doing. So this population is, because it triggers people in so many different ways, you're going to have every type of individual coming into your office. So when someone like this comes in and you could possibly be triggered, you might tend to be a little confrontational with them, and with these types of individuals, you just have to really check yourself as a therapist and make sure that you're not doing that. So obviously developing a trusting relationship is important in all, but maybe a little more important when it comes to these individuals. The legal and sentencing process kind of ties into that. So these individuals, the trial and sentencing process for pedophiles is very long and super complex. So they have been involved and immersed in this for probably months, could even be a year before they come to see you. They have lawyers telling them through this process to deny or not fully disclose all of their behaviors to avoid either further ridicule or further sentencing from the court. Basically just been told to just hide everything, and now they're being put in front of you and expected to kind of disclose all of their deepest, darkest secrets. This was actually shocking to me, and what worries me about this process, and as therapists, this is where I really think our job comes into play. So the mean victims among sex offenders is around 148. That's the mean. When they fully disclose, that's around the average number of people, and they won't disclose this because their sentence will be so much further than it is. So obviously confidentiality is huge, and you want to build that relationship with your clients so that if there are more victims, we find out about them, we can help them as well. When it comes to treatment planning and goals, so there's a specific type of treatment that we would use with this individual, or these types of individuals with pedophilic disorder, and it's motivational interviewing. So why we would use that type of therapy as one of the many that you can use is that it moves clients from the pre-contemplation to the contemplation stage, which moves them towards the engagement process of treatment that I was talking about earlier, that they're a little hesitant to get involved in. Relationship building is huge, so obviously you want to build that trust, like I said before, because there's always a reason why the client is acting like they're acting. Whether you're being confrontational as a therapist, or they don't like necessarily your nonverbal body language, or it could just honestly be their history and what they've gone through personally that could be triggering them and making them a little less hesitant to engage. With that being said, the last thing, and probably one of the most important things, is self-care and wellness as a therapist. So I've touched on this several times about how this is a very touchy subject for therapists, and a lot of people